Hello, everyone, and welcome to the HHQI Cardiovascular Learning Action Network. This is our live event for September 2018, and we'd like to welcome all of you, whether you're listening to the archive recording or whether you are participating in the live event. We thank you for your time. We're very excited about today's presentation, and we hope that you're going to be able to apply some of the content that we're going to cover today immediately afterwards. It's one of those types of events. Few housekeeping items. The lines are currently muted. All lines will remain muted because of the volume of callers. We encourage you to use the chat feature on the right-hand side in the Q&As. Make sure that you send those Q&As out to everyone so that we can all participate in it. But we will be asking and answering those questions as much as we have time for throughout today's presentation. So make sure to go ahead and get started getting your questions in as you have them, because we do have a guest expert with us today, and hopefully we'll be able to address everything that comes in. Now, as far as a few announcements, normally I like to present these really early on, but what I'm going to do is hold off on the announcements, and we'll see how much time we have at the end, because today's content, it's one of those that we've been working towards for a long time, and we're very excited about it. So we're going to go ahead and jump on into it. We do need to remind everyone that today's event has been approved for 1.25 hours of continuing education for nurses, and it is available through the HHQI University. Following this webinar, you're going to be redirected to the university. You've already watched the webinar if you are participating live. If you are watching the recording, you'll need to watch the webinar. Then you'll have to answer very short evaluation and reflective questions. That should take you no more than 15 minutes. I do need to remind you that all of this is approved by the Alabama State Nurses Association. It is an accredited approver of the nursing continuing education through the American Nurses Credentialing Center Commission on Accreditation, or the ANCC, and is accepted in all 50 states. Now let's get to the good stuff. The objectives of today. We hope at the end of this webinar you're going to be able to explain 2 scientific causes of cardiovascular disease. Hopefully you're going to be able to identify 3 therapeutic lifestyle changes that can really reduce the risk of cardiovascular disease, not only for your patients, but for you and your family as well. And finally, we hope that you're going to be able to describe the healthy diet to help reduce cardiovascular disease, going a little further into it than we normally do when we think about this. You can read along with me to end this today as we talk about our guest expert. We are so excited to have Janine Dre-Darius. You can read it. She has her master's in health science with an emphasis on nutrition and dietetics from the University of North Florida, a BS in food science and human nutrition and dietetics, University of Florida at Gainesville. She's currently a professor of medical nutrition therapy, the ISPP coordinator for nutrition and dietetics department at UNF at the Independent Supervised Practice Program. And this part I think is one of the most exciting, is that she is currently enrolled in the doctorate for clinical nutrition, the DCN, and her expected graduation date is 2019 from the University of North Florida. So we're very pleased to introduce doctoral candidate Janine Dre-Darius. I will turn this over to you.
Thank you, Cindy, and hello, everybody. So today we're talking about cardiovascular disease and reduction of risk and treatment through diet and lifestyle changes. So 1/3 of all deaths in the world now are actually caused by cardiovascular disease. This includes all heart diseases and stroke, and that is a new study that came out and that was done over the past 25 years. And as you'll see further in, is that the United States falls right into that 1/3 people dying of cardiovascular disease. So of course, this is something we want to prevent and treat if somebody does have it. On this slide, you see that cardiovascular disease actually claims more lives each year than all forms of cancer and chronic lower respiratory disease. So that's big. You can see the circles there. There's the orange and the red circles. All combined don't make up for what cardiovascular disease is doing in this country and across the world. So facts about cardiovascular disease. It's listed as the underlying cause of death, accounts for nearly 800,000 deaths per year in the U.S., and that's, again, 1 of every 3rd death in the U.S. is caused by this disease. About 2,300 Americans die of cardiovascular disease each day, an average of 1 death per 38 seconds. About 92 million American adults are living with some form of cardiovascular disease, known or unknown, and then some of them have the after effects of actually already having a stroke. So the direct and the indirect cost of cardiovascular disease in this country is well over $300 billion. So again, trying to treat it is great, but what we really want to do is try to prevent it. So we're going to concentrate on some prevention today, mostly prevention, and then some treatment once somebody does get it. So what causes cardiovascular disease? Of course, we have our risk factors that are not modifiable. We have age, we have gender, genetics, family history, and then if a prior event has happened. So those are not modifiable. But you can see on the right-hand side, we have many things that we can change in our lives and in our patients' lives to try to prevent cardiovascular disease. And those include their cholesterol levels, keeping their hypertension under control, preventing type 2 diabetes, which we know now through DPP programs, preventative programs, we can prevent type 2 diabetes, helping people with obesity, stopping smoking, of course, everybody knows that one. Physical inactivity is a huge factor, especially in this country, and stress. A lot of people don't think about that, but stress is one of those things that can cause cardiovascular disease because of hypertension. Excessive alcohol intake, and then of course we're going to talk in depth about an unhealthy diet and how to improve our diet and make that better. So atherosclerosis is what actually is cardiovascular disease is caused by. So it's the narrowing of the arteries. It happens in more than one part of the body. If it happens around the heart, it's known as coronary artery disease, or CAD. And if it happens in the legs, it's called PAD, or peripheral artery disease. So these are what we're going to be looking at actually causes atherosclerosis, which leads to cardiovascular disease. So we're going to start with looking at the risk factors. The first one is cholesterol. So cholesterol does come from food. We'll talk a little about that, but it actually is something that your body produces automatically. You do not have to take any cholesterol into your body in order to have enough. So realistically, any cholesterol we're taking in is probably too much. So we're trying to reduce our cholesterol intake. When cholesterol gets too high, the levels are out of balance, which is dyslipidemia. The cholesterol can clog those arteries and will start affecting the flow of that blood, and the blood won't be able to go through. So we're going to talk about foods that contain cholesterol and how to reduce that. The second risk factor is hypertension. So hypertension is defined as when your systolic blood pressure is less than 120. So that's a good optimal blood pressure. And that's a new number that came out not too long ago. So when your vessels actually get blocked, your heart has to work harder, and when they're pumping the blood through that smaller space, it creates pressure. That pressure on the artery walls weakens them, and this makes that area more susceptible to atherosclerosis. So that's why hypertension is one of the things through diet we want to try to prevent. The next risk factor is type 2 diabetes. Many studies have reported that the factors that have increased, including increased oxidative stress, increased coagulability, endothelial dysfunction, and automatic neuropathy are often present in patients with diabetes, and this will directly contribute to the development of cardiovascular disease. We do know that people with diabetes, that 2/3 of the deaths that are actually attributed to cardiovascular disease. So we want to prevent diabetes so that they don't die of cardiovascular disease, which again is very preventable. So this slide represents a direct indicator of body weight and coronary artery disease. or coronary heart disease. So there is a direct risk, and you can see from the bottom, if you have a BMI of 19 or even up to 24.9, you have a very low risk of dying from coronary artery disease. As it gets above 25 and then above that overweight range of 28, 29, gets into the obese range, and you can see the obese range, class 1, 32 BMI, you have a much higher chance of dying from coronary artery disease. But we also know that every bit helps. So for the people who are overweight, in those cases, if they just lose 10% of their body weight, it can improve or prevent an obesity-related risk factor for cardiovascular disease. So decreasing their weight can absolutely help, even if it's just a small amount. And we all know that one of the major risk factors is smoking. Smoking has a 100% increase in risk for stroke, coronary artery disease, heart disease, 300% increase in risk from death for undiagnosed coronary heart disease, more than 300% increase in risk for PAD, and then a 400% increased risk for aortic aneurysm. So stopping smoking and getting our patients to stop smoking is a very good way of preventing cardiovascular disease. Physical inactivity. Basically, if you are active and you are moving and we're trying to do our 10,000 steps, you can prevent cardiovascular disease, whatever your age, whatever your fitness level, trying to get your patients or trying to get moving is what we want to do for cardiovascular disease. The next risk factor is stress. So high stress levels increase the risk of cardiovascular disease by causing prolonged high blood pressure and a faster heart rate. So we do know that stress is definitely a risk factor. So the dietary factors that affect our blood lipids, the first one we're going to talk about is saturated fatty acids. So sources of saturated fats in our diet include any lard or fat in beef or pork or lamb, milk fat, such as in butter. There's also ones that aren't animal, are coconut oil and kernel oil. Saturated fatty acids are associated with cardiovascular disease and the progression of it. So eating a high-fat diet, fatty milk, cheese, butter, bakery goods, fast foods, and snacks will actually cause and continue to exacerbate cardiovascular disease. So the American diet, the Western diet, which is what we call SAD, the intake of saturated fats is around 11% of the calories of your energy intake. What we're trying to get that down to is below 7%, and you'll see that coming up when we start talking more about saturated fat. So the first diet pattern we're going to talk about, which is a lot of times a doctor will tell somebody, we want you to eat less fat. And when they're saying that, they're wanting to decrease their fat down, again, that saturated fat to 7 to 10%. Trans fats, less than 1%, 0% of trans fats would be great. Those are the fats that are found in your shelf-stable pastries and your processed foods. So we want to try to get rid of those out of our diet altogether. We want to increase our intake as we're decreasing our intake of saturated fats, unsaturated fats, included your monounsaturated, and then your omegas, which are your nuts and your fish. And then we want to be taking, and there's that cholesterol, that less than 300 milligrams a day of cholesterol to make sure that our cholesterol is not going up. A low-fat diet with energy restriction may present an alternative for the typical Western diet. So basically, this is just a basic general rule of trying to get people to eat less fat. The problem with this particular diet, when we tell people to eat less fat, they tend to start eating more carbohydrates, and not good carbohydrates, not the healthy ones. They tend to eat more processed foods and sugary things and sweet things. instead of those fats, because fats actually help you feel more full. So if they're not eating those fats, they're going to replace it with something else. And a lot of times that does end up being those carbohydrates that we don't necessarily want them to be eating. So we're going to talk about 3 diet regimens that are really popular in the news that you guys have probably heard about. And these 3 diets all have effect on hypertension and cholesterol and weight, actually. The 3 diets are the TLC diet, which is the one you see here, the DASH diet, and then we're going to talk a little about the Mediterranean diet. So the first one we're going to look at is the TLC diet. This is a Therapeutic Lifestyle Changes diet, and it has actually come out as one of the top, along with DASH diets out in America. This is not really considered a diet, though. This is actually considered a lifestyle change or a long-term nutrition style change. It is a healthy eating plan. It is not a fad diet. It can help anyone to lower his or her cholesterol. So in a world where fast food and convenience foods are really popular, many children and teenagers are also at risk for high cholesterol. And by following this diet, an entire family could actually get their heart on track and for a long-term process. One of the main changes you'll make is cutting down on your intake of foods with saturated fat, and because these fats are known for causing high cholesterol. So the therapeutic diet looks like this as far as a composition. So there's our saturated fat where we're doing less than 7%. And we'll talk about foods later, and we'll look at what foods contain these and what we would need to reduce. And then your polyunsaturated, up to 10%. Your monounsaturated, again, those are your more healthy, your avocado and your nuts. Your total fat down to 25 to 35% of calories. Carbohydrates 50 to 60%. Again, that's healthy carbohydrates. And increasing our fiber is a huge one of the things we'll talk about also. Getting that up for women, it should be 25, for men up to 38 grams. Protein, approximately 15%. Again, those are going to be lean meats. And this one actually says cholesterol to be below that 200 milligrams, so they're reducing it even further. And then total calories is just for energy balance. So they're just making sure that your calories, so you're not, if you're at a desired weight, you're not gaining weight or you're not losing weight. So the American Heart Association supports the TLC diet, and it is a good diet for your heart. And it can bring your cholesterol levels down if you're experiencing high cholesterol, but it can also keep you from possibly going on medications, is the way that they tout this diet. Again, it's just one of the second highest touted diets or talked about diets in the news. So what does the TLC diet look like? Whole grain cereals greater than 6 servings. So it's higher in carbohydrates, high in fruits and vegetables, so it's 3 to 5 servings of vegetables a day. Those are a half a cup of cooked vegetables, or a cup of uncooked vegetables would be a serving, and then your fruit, a small piece of fruit, 2 to 4 servings a day. Dairy products, low-fat dairy products, 2 to 3 servings a day. On this one, they're restricting your eggs to, you can have egg whites, but they don't want you to have more than 2 egg yolks per week. And then meat, fish or poultry, any type of meat product that would have fat in it would be less than 5 ounces, and then fats and oils are limited and adjust as you can for your calories. So the TLC diet, what you want to eat more of here is your fresh, frozen, canned vegetables, as long as they're not, don't have sodium in them. But we're really looking in this particular diet at the fat. So non-fat or 0.5% low-fat milk, yogurt, and cheeses. So none of the full-fat ones there. Unsaturated oils like your olive oils or your soft or liquid margarine or spreads or salad dressings. And then there's your seeds and your nuts for your healthy fat. Eating lean cuts of meat, extra lean hamburger, fish, or even alternatives that, you know, eating Mondays, you know, once a week, vegetarian day of eating those meat alternatives or just leaving meat out altogether. And then whole grain breads and cereals, that's your, you know, your brown pastas, your brown rice, potatoes. Beans are an awesome choice for protein and for a low-fat protein source. And then if you're snacking, low-fat crackers, and then pretzels, and then low-fat cookies instead of chips and things like that. So the next one is eat less of these. So here's our less donuts, less biscuits, less chips, buttered popcorn, whole or reduced fat milks, less ice cream, half and half cream cheese, sour cream, whole eggs, like I said, egg whites are fine. Less of the fatty meats like ribs and T-bones, organ meats, or fried meat, you know, which is a really popular thing down in the South. So trying to reduce that, the fried chicken, and maybe doing baked chicken. And then butter, of course, stick margarine. Chocolate is listed in there, but if it's 70% cocoa, chocolate can be considered a healthy treat. But if it's like your milk chocolates, it has that saturated fat in it also. So this particular diet does concentrate on fat, whereas when we start talking about the DASH diet compared to the TLC diet, you'll notice that the DASH diet, which stands for Dietary Approaches to Stop Hypertension, actually concentrates more on an overall change than just concentrating on fat. So we'll talk about the DASH diet now. So this is the #1 diet in America. It was conceived by American doctors for people who suffer from hypertension. It is recommended by the American Heart Association, and we're going to look at it a little bit closer, but it is comprised of all your whole food products, your vegetables, fruits, dairy, grains, protein, nuts, fish. It is low in sugar, it is low in saturated fat, it decreases meat, and of course it tries to decrease the sodium. So the reason this became a popular diet is there was a trial, it was a randomized trial where they tested whether counseling to make simultaneous lifestyle changes could prevent or control high blood pressure. So they took about 800 people in 4 different locations, and they followed the DASH diet. They did some physical activity. They restricted their sodium and their alcohol, and this resulted in the adults with high blood pressure. One sec. Sorry about that. To reduce the risk of heart disease. So it was a study that was done in 2003. And this diet regimen is recommended for people with high blood pressure, but it's also recommended for if you're avoiding high blood pressure, also if you have friends in your family. And for a bonus, what they found out is this diet can help you lose weight. So again, that's why it's the #1 diet. It's a little bit easier to follow than the TLC diet. So here's what a DASH diet would look like. Again, it looks pretty similar to a normal healthy diet in the TLC diet. Fresh fruits and vegetables, whole grains, lean proteins, beans, nuts, and seeds, low-fat dairy, and then fats, and limiting your fats and your sweets. The foods that are contained in the DASH diet, basically you're eating a whole nutrition, and you're getting all the nutrition that your body needs so that you won't end up feeling like you're missing something, and you'll be getting the right vitamins. And so it's not like a fad diet where you're actually getting everything that your body needs, and it's pretty easy to follow. So we've talked about the TLC diet, which is more for controlling your cholesterol by lowering fat intake. And the DASH diet is the one that's related to hypertension. So you're eating a varied amount diet, reducing the amount of salt, increasing the amount of potassium foods by eating more fruits and vegetables, and you're able to control your hypertension and prevent cardiovascular disease with this diet. So the last diet that I'm going to talk about before we get into talk about specific foods is the Mediterranean diet. So the Mediterranean diet is based on eating more plant-based foods, including, again, the same as the other fruits and vegetables and whole grains. This replaces butter with healthy fats. So it is considered a higher fat diet than the other two, but you're using olive oil and monounsaturated fats instead of any of your saturated ones. It also uses a lot of herbs and spices for cooking instead of using salt. They limit red meat in this to no more than a few times a month, but you can eat fish, and they recommend fish a couple times a week for omega-3s, and you can also have poultry, so you can do that a couple times a week. So again, it goes more to eating more of a plant-based diet. But the one thing that they do with the Mediterranean diet is they do say drinking red wine in moderation is okay, and we'll talk about what moderation looks like. It is controversial because of the little bit higher in fat, and then that it includes the alcohol or the wine. But adherence to this seems to be a little better than some of the other diets because it's a little more flexible. But it is also associated with a decreased risk in cardiovascular disease. So now we're going to talk about specific recommendations for specific foods. So here's the list of the ones we're going to talk about. So the first one we're going to talk about is whole grains. And the reason we want to be eating whole grains is for soluble and insoluble fiber. Fiber helps you feel more full, and there's some good research that I have here on this slide letting us know that the consumption of higher amounts of fiber is going to decrease your risk of cardiovascular disease. So the current guidelines for dietary fiber at this time, again, is 25 grams for women and 38 grams for men. But if you can eat higher fiber, even higher than that, you can see that that first study I have up there, they included 56 to 85 grams of fiber. So by eating higher fiber, you have less chance of getting cardiovascular disease, has been very proven in many studies. The idea behind fiber, though, if you start recommending fiber to people, you've got to start recommending more fluid also, and recommending that they increase their fiber slowly. And the mechanisms that go along with this is it actually increases bile acid fecal excretion, but it also decreases the lipid absorption, so it doesn't absorb in. It's actually removed from your system. So increasing fiber is definitely one of those things, and doing that by eating whole grains. So that's the big reason that we continue to recommend whole grains. And fruits and vegetables come into that also with fiber. Interestingly enough, we do know that by eating more fruits and vegetables, it can lower your blood pressure and lower your risk for cardiovascular disease. It can also lower your cholesterol levels by eating more fruits and vegetables. So recommended is 8 servings of fruits and vegetables a day. Most Americans get 3 if they're lucky. So just trying to get people to increase this would, and again, it's high fiber, high antioxidants. Eating by the rainbow is typically what I like to tell people. Fruits and vegetables are low calorie, they're low sodium. You know, what could be better than pulling an apple off of a tree and, you know, feeling good about what you're eating. So fruits and vegetables are a huge part of changing people's diet, of getting them to eat more of those and putting down the fatty carbohydrates that we tend to eat. So nuts keep coming up also. Nuts are high in fat, but there is a positive association between nut intake and the decrease in cardiovascular disease. So it's showing that high nut intake is actually will give you 35% risk reduction for cardiovascular disease, and that was a pretty big study that they did there. There have been many more trials and studies that have been done with this. Possible mechanism is the polyunsaturated, and they are actually low in saturated fats, and the phytochemicals, micronutrients that are in nuts. They don't know exactly what those nutrients are doing, but they do know that it helps in the oxidation and the inflammation in people. So it is recommended to consume about 20 to 30 grams, and that looks like about a handful of nuts a day. And it can be any kind of nuts. The most healthy ones tend to be walnuts. Almonds tend to be eaten more, but walnuts actually have a higher dose of your omega-3 oils in them. So any kind of nut, but a handful of nuts a day is definitely something we should be recommending and doing to fight cardiovascular disease. So there is conflicting information about dairy products. There isn't a lot of good research out there talking about specific dairy products. There is one big study where they reduced the risk of subjects with individuals with the highest dairy consumption actually had the lowest cause of death through stroke. So there is a relationship, but a bigger relationship is the fermented milk that can actually help to lower blood pressure, like kefir, anything like even your yogurt or your any fermented, your kimchi, those drinks they have out now can actually lower blood pressure. So recommendations remain, because there isn't good research saying one way or the other, to 2 to 3 portions of low-fat, low-sugar dairy products. And there is no evidence that by taking calcium or vitamin D supplement it can prevent cardiovascular disease, which was one of the myths that were out there for a little bit. So here's alcohol, moderate intake of alcohol, 1 to 2 drinks a day. So it ends up being that women can have 1 drink and men can have 2, and that's considered moderate. And this can reduce the risk of cardiovascular disease. We don't want to be recommending alcohol for people who don't drink, just because it could be healthy for them. But if people are drinking, they should not be drinking more than 1 to 2 drinks a day. And you'll see on the second line where it says binge drinking had doubled the total CV mortality risk than regular drinking. So I teach at a university, and my students always think they can have all 7 drinks on Friday night. We try to tell them that that doesn't work. It's still going to increase the risk for cardiovascular disease. So excessive consumption is associated with hypertension, excessive weight, and cancer, which will eventually lead to cardiovascular disease. And then individuals with liver disease, fatty liver, high triglycerides, hypertension should all avoid any type of alcohol consumption. So when we're talking about drinking, 1 drink is considered either a 12-ounce beer, a 1-ounce drink of what we call hard alcohol, or 5 ounces of red or white wine. So those are the serving sizes for alcohol. And coffee is another interesting, because you hear good things and bad things in the news all the time about coffee. And about 80 to 90% of adults report drinking some amount of coffee. So the recommendation is under 400 milligrams a day of coffee in order not to increase your cardiovascular risk. Besides caffeine, coffee does contain some good things, flavonoids and various lipid-soluble compounds. The problem with coffee is it is dependent on your genetic makeup. It's what they know now. So they do know that genetically there are fast metabolizers and there are slow metabolizers of coffee. So if you're a fast metabolizer, it's good for you because it works out of your system faster. And if you're a slow metabolizer of coffee, then it stays in your system longer and can actually cause heart problems. So again, there is modest evidence that it will prevent getting cardiovascular disease and type 2 diabetes when consumed under 4 cups, but it really does depend on your genetic makeup. Tea is another good one. We hear all kinds of good things about tea. Green tea particularly, and also black tea, but 1 cup a day is decreased with is associated with a 10% decrease in your risk for cardiovascular disease. There were some other studies done that you had greater than 3 cups actually lowered your risk of a stroke by 21%. So the mechanism for tea is it has anti-inflammatory properties. It also has antioxidant effects, and it favorably affects your endothelial function. So it helps your body to function better. So we want to be drinking tea, maybe replacing our coffee with tea in the afternoon. It's something they do in other countries. Most countries do drink tea, but it is one of those things that would be beneficial for somebody who is trying to prevent cardiovascular disease. So here's chocolate. We talked about a little about that earlier. So cocoa is rich in polyphenols. Polyphenols are good for you. So if you're eating plain cocoa, you're eating something that's good for you. But what we do is we take this chocolate and we add a whole bunch of saturated fat to it, and it ends up making it not good for us. So what we recommend is dark chocolate. And that dark chocolate will actually lower your risk of cardiovascular disease by 29%, and there is research out there, and 29% reduction in stroke. But actually eating it for prevention is not good, not recommended. It's not what we're recommending. But if someone likes chocolate and they want to have a 1 ounce piece and they're eating the type that has 70% cocoa in it, it is not a bad thing. It is actually okay. The next one is garlic. Again, garlic's been out there for a while talking about cardiovascular disease. It is attributed to favorable cardiovascular effects. It has thiosulfonates in it that actually help to prevent cardiovascular disease, but you have to actually eat quite a bit of it. The recommendation here is eating 2 garlic cloves a day, and it may reduce blood cholesterol levels. But once you cook it, it actually reduces that. So the heat actually deactivates some of the healthy products in garlic, so it ends up not being as healthy. And if you're taking a garlic tablet, definitely does not work. It has to be actual real garlic. And so omega-3s, at this point right now, doctors are recommending people to take a supplement of 1 gram of omega-3 daily to reduce risk of cardiovascular disease and non-fatal myocardial infarctions and non-fatal strokes. So instead of taking a supplement, we could be eating fish twice a week. The one research says 1 fatty fish meal a week resulted in 50% decrease in risk of cardiac arrest. So what we try to do is recommend people to eat fish twice a week if they like fish. If they do not like fish, taking a supplement is definitely okay, and it has been proven to be beneficial. And eggs are controversial also, and you can see from the TLC diet that they recommend only 2 egg yolks a week. Some of the other diets don't restrict it as much. The actual recommendation is consumption of 5 eggs a week does not significantly increase cardiovascular disease in healthy people. So up to 5, and they have done some research that says that up to 5 eggs is okay. But if you already have high cholesterol, it's not recommended to do more than the 2 yolks like the TLC diet. And eggs are good. They are good fat. They are good protein. They're inexpensive. They're easy for people to cook. They're easy for them to have for breakfast. So they are a good recommendation. And most studies found no association between the egg and getting cardiovascular disease. So we do continue to recommend up to 5 eggs a week for most people. And then there's stanols and sterols. These are found in soybean oils and pine tree oils, and they're making functional foods. You can see the picture there for the Benecol. And what they have found in research right now is that consuming 2 to 3 grams a day lowers cholesterol by 9 to 20% in persons who already have high cholesterol. And it does that by inhibiting the absorption of dietary cholesterol. So these are functional foods that we're seeing out there that can actually help to lower cholesterol. And again, Benecol is definitely one of them that's been out in the market for a while. So general dietary recommendations. These general dietary recommendations are recommended by the National Institute for Healthcare Excellence, European Society of Cardiology, the American Heart Association, and then the American College for Cardiologists. So we're going to kind of go backwards, and we're going to talk about each one of these. The general dietary recommendations. The first one is energy balance. The typical way that we figure out how somebody, how much energy they need is it has, I mean, depending on whether they're exercising or not exercising is a big factor. If they start increasing their exercise and they're trying to lose weight, we don't necessarily increase how much energy they need or how many calories they need. So a good rule of thumb is taking somebody's weight and adding a 0 to it. So if you weigh 150, 1,500 calories, plus adding if they're doing exercise. So we want to make sure that people are staying within their energy balance. And then reducing saturated fats intake, reducing their butter, reducing their fried foods, if we can do that. And then increasing their seeds and their nuts and their avocados to get those healthy fats in there. Fats are something that help us feel full and will make us eat less, but they are also very calorie dense. So when you think even about a healthy fat, like an avocado, we think of that as a healthy fat. If you're eating half that avocado, you're eating of a small one, you're eating about 250 calories. And that's fine as long as you're counting those calories, and that the fat in that will actually help you feel full for longer. And that goes the same along with nuts. You know, if you sit down on the couch with a whole bag full of nuts and you think that's healthy for you, you're eating a lot of calories with those nuts. So trying to get, our patients and trying to get the people we know to only eat a handful of nuts sometimes is really tough. But we need to get those fats are still fat and they're still high in calories, but we need to take away the bad fats and replace them with the good fat. So increasing that fiber, women 25 grams of fiber is what we're looking for, and for men it's 38 grams. You'd be surprised when you sit down and a normal American only eats about 14 grams of fiber a day. And so it's about half for women about what we should be eating. So we can get more fiber. Now, even those foods that they're adding fiber to that you see, like the bars that are like the Fiber 1 bars, that fiber is an inulin fiber. It is perfectly safe. It is perfectly fine for increasing fiber. But to try to increase fiber to prevent cardiovascular disease is a pretty easy way of getting people to make some small changes. But again, making sure we're recommending or we're increasing that water intake to go along with it. Increasing the intake of fruits and vegetables. This is a big one because it's definitely not easy. Fruits and vegetables tend to be more costly than some other foods that you could snack on. They take longer to prepare, although frozen is just as good as fresh. So if you can get your clients or you can get your family to, eat frozen vegetables, that's fine also. But just trying to increase, and we're looking for 8 servings of fruits and vegetables a day, which is a lot. If you actually went through what you ate today, most people probably eat about 3 or 4 servings at the very most of fruits and vegetables. The other general recommendation is increase our fish intake. Again, that has to do with those omegas that we know for a fact stop people from getting cardiovascular disease. In those countries where they eat fish in really low beef amounts, they have a 50% reduction in cardiovascular disease. So eating any kind of, especially your fatty fish like your salmon and your mackerel or your tuna or something like that that has those good fats in them, those omega 3s and 6s. Limiting alcohol consumption. I've traveled around the world, and alcohol is a bigger deal here in the United States than it is in other countries. In Italy, they have a glass of wine with dinner. They have a glass of wine with lunch. So those 1 or 2 glasses of wine a day, and they have obesity rates, diabetes rates, cardiovascular disease rates are really low in those countries. So limiting alcohol consumption, but still allowing yourself to have 1 or 2 drinks if you want those. Reducing salt comes with everything we've been doing. If you eat more fruits and vegetables and more whole foods, less processed foods, less fried foods, you're going to be reducing your salt. The salt, then the salt intake is around 2,300 milligrams is what we recommend. If someone already has hypertension, we actually go down below a 2 gram or 2,000 milligrams, which is hard to do if you're eating any type of processed foods, especially soups. If you're pulling soups off the shelf, reducing salt is hard to do that. Now, making your own soups, again, time-consuming, but you can definitely control the salt in that, but trying to control our salt intake. The next one is reducing sugars, just, staying away from those donuts and those snacks. Not always, just, not on a daily basis. Those should be really something that would, you have as a special treat. And the reducing of trans fats are those fats that are the shelf-stable. They came about in the 1980s, and the world kind of they thought that was going to be better for them than like eating butter, or they started using them for frying things. A lot of the companies have pulled the trans fats out now, and hopefully they're being all pulled out. But reducing trans fats, the only way you can do that is stop eating those, those cookies, and stop eating the things that the fried foods, and to get away from trans fats. So recommending, baked things and not things that have been processed, not all the processed foods. The other general dietary recommendation is meal frequency. There was a time where we used to recommend people to eat 6 small meals. What the research came out on that, it says that if people are eating 6 small meals, they're overeating 6 times a day instead of 3 times a day is what that ends up being. So getting our meal frequency down to those 3 times a day, and maybe having a snack 1 or 2 times a day, but making sure that those are snacks, that they're not full meals, is again one of the general dietary recommendations for keeping your weight down and keeping cardiovascular disease at a bay. And there's references and any questions.
Well, thank you for that. I had to get a quick giggle on your comment about the 6 small meals. That's something we've been seeing for a while now, so that's, I'm glad that there's starting to be evidence out there about it. All right, we do have a few questions coming in, but in the meantime, if those of you are in the audience do have additional questions, go ahead and keep sending them in through chat, and we'll get to as many as we can. So in no particular order, we'll go ahead and get started. First question is, with the increase of fruits and generous allowance of 6 to 8 servings, are we concerned about the sugars in the fruit?
We are not. And unless you, and even for diabetics now, they're not recommending that we reduce those. We're recommending that we use those as part of like a meal, like the sweet part of ending a meal. We are not worried about, people aren't going to overeat on fruit. They're going to overeat on donuts, but not on fruit is what we typically see.
Understandable. Now, that was a 2-part question, and the second part of it is there a problem, or is there anything specific we need to keep in mind with tracking the sugar content of a particular fruit, thinking about the time of picking, the size, things of that nature?
That is a very good question. I do not, I've not read up on any of that. And even when we're going through these recommendations for cardiovascular disease, they're saying frozen, they're saying fresh, they're saying even canned as long as it's not added sugar to it. So fruit itself, yes, has sugar, but it's not something we're worried about, because along with that sugar, there's pectin and there's fiber and there's phytochemicals that we don't know what's doing in there. So we do kind of know that they are better for you, but I don't know if different seasons changes that or not.
That sounds great. Kind of a 2-part question again. It's just a combination of 2. Is there a minimum level of sodium that we need to take in?
That is a very good question. It does depend on you. It depends on each person is different. Your body does need some sodium, and we do know that. I was doing a research project on people who had CHF, where they normally restrict their sodium down to like 1,000 1,200 milligrams. And what they found is when they were restricting them that low is they were actually dying sooner than the people who were eating the 2,000 or the 2,500 milligrams. So yes, we do need a certain amount of sodium. I don't think in our diet we could ever go that low naturally. If you're eating any, there's so many things that have natural salt in them, like tomatoes is a big one, or some of your fruits or some of your vegetables has natural sodium in them. But yeah, anything below your 1,500 milligrams of salt is going to be really low and probably not really good for you.
Okay, thank you for that. Another question that came in that was similar is, what is the recommendation level for carbohydrates? How many grams per day?
Okay, that's a good question too. So a normal American eats about 600 grams a day of carbohydrates. The recommendation, the lowest amount of carbohydrates you should have in a day is 130 grams. So when people are going on these really low carbohydrate diets, they're not doing their body any good, because that 130 grams is what it takes your brain to function correctly. So you need 130 grams of carbohydrates for your brain to function. So that's the lowest. And then depending on, what the chronic disease is, if you have a chronic disease or don't, I'm also a diabetic educator, and what I recommend for my patients is around 60 grams per meal, 3 meals a day, so that's 180. And they might have a snack that's 30, so that's about 210. But if you can get anything below that 600 to 400, 600 that normal Americans are eating, you're actually doing a pretty good job. And then again, it's not just carbohydrates, it's the type of carbohydrates. You want to stay away from the, the sweet, sugary things and try to eat more fruits and vegetables, more whole grains, that kind of thing. So good carbohydrates is the difference.
That's a great distinction. Thank you again for that. The next question is, are sterols and stanils available and effective in a supplement form?
I haven't seen the research. It's relatively new, but I do not think they are available in a supplement form. Like I said, they are adding them to functional foods, and let me tell you some foods they come in naturally. So sesame oil, wheat germ and wheat germ oil, pistachio nuts, olive oil, some of your herbs, sage, oregano, thyme, paprika, coconut butter oil, almond butter, sesame seeds, and macadamia nuts are some of your top foods that have sterols in them. So you can actually get small amounts, and it's really only small amounts that you need from regular foods. It's just that by them adding them as functional products to those other foods, they're actually seeing a decrease in cardiovascular disease, which is awesome to see. But I don't think you can get them in a supplement form at this time.
Okay, thank you. And I want to remind everyone to continue to send in your questions. We are continuing to go through these, but don't hesitate, send them in, and if we are not able to get to them by the end of today, we will contact you with the answer in another form. Next question is, I've been told by someone that coconut oil is a different type of saturated fat by a patient. They seem to indicate that it was not harmful because of this reason. This person is using it daily to help with constipation. How should I respond to this person?
Okay, that is good. So the research that came out with coconut oil it's slightly better than olive oil as far as if you're using it in the amounts. Like if you use olive oil and you use like a teaspoon to cook your food in, and you wanted to use coconut oil instead, it's slightly better. That's the newest research. But just using it and using more of it because you think it's better for you it's still a saturated fat. It's still not good for you. Now, someone taking it for constipation, if it's working for them, great, but it could also, create issues later with cardiovascular disease. So it's, again, I always say that fat is fat is fat. If it's fat, it's still not good for you. There's just some that are better than others, and using a little bit of coconut oil, instead of using butter is great. Using a whole bunch of coconut oil instead of using a little bit of olive oil is not great.
Very clear. Thank you. The next question is, in terms of behavior modification, how can home care workers educate patients regarding diet in the best possible way?
That I mean, it depends on what their diet is and whether they want you to help them is the other side. But what you would want to do is have, I would, if I was someone going into somebody's house, and I would carry educational material with me. If someone asked me about something, that way you're carrying information that's coming from other places, like the American Heart Association or, NICE or whoever, and have, and give them the information that comes from the people who know what they're talking about, and supplying that to them. Because most of the ones who are probably at home are probably, like my mom here, listening to Dr. Oz, and I come home and she's like, well, Dr. Oz says, and giving them solid information and give it to writing makes sense.
I like that. And also to reiterate one of the points you made early on in that, it's all about self-management when it comes to educating our patients, especially those in the home, and motivational interviewing with TeachFacts. So for those of you that, and it doesn't matter really if we're talking about diet, we're talking about medications, we're talking about safety, false precautions, whatever it is, you hit the nail on the head, is that the patient needs to be, or the patient or our parents or our families need to be ready to hear it. And that's where we can integrate a lot of the self-management concepts. So for the asking of that particular question that way, I think you are right. It is the person needs to be ready, but we also have to have the expert knowledge behind us, our evidence-based, to base our practice on. Okay, one more question. Can you advise on cooking with salt, particularly in those low-salt heart failure restrictions? How much is okay to add to a pot of soup, as an example?
I don't add any. So I'm making a pot of soup, right? And I'm using vegetables, and I'm using potatoes, and I'm using all kinds of good, healthy stuff that tastes good, and I'm throwing beans in there, right? It has a certain amount of sodium in it already. I really do not add any sodium to it. What I do is if we sit down at a table and my family starts eating their soup and they think it needs a little bit more flavor or a little bit more something, I do have other things on the table that they can use, and if they want to go for salt, they can. We have no chronic conditions here. But I wouldn't add it. I'd let them add it at the table.
Sounds wonderful. I want to thank you for taking the time to answer those questions. And there's one final comment that came in that I'd like to reiterate as well, as thank you for comparing the various diets and going into the specific food categories. This has been very helpful. Now, as I mentioned before, we're going to move the announcements towards the end, and I want to just take a quick second here to go over a few resources that are available to expand on this content. They are hyperlinked on these slides. You can find these in the HHQI resource library. This particular following the DASH eating plan. You can also find a wonderful chart that will show you how many I can't come up with words, how far you can reduce the blood pressure with minimal amounts of lifestyle modifications. These are all very helpful, and especially with working with your families and your different patients. Most of these are translated into Spanish, as you will see here. There are a couple different ones, as well as different university courses where you can expand and still earn CEs in this way. Now, for today's event, the step-by-step flyer on how to access this particular university course and to receive your CEs, to follow this hyperlink. And in step 3, where it's asked what course catalog, select the Cardiovascular Health course catalog, and from there it will be pretty self-explanatory. If you have any questions or difficulties, you can contact us at hhqi@qualityinsights.org. Do remember that this particular university setting, you need to only have one username. If you've forgotten your username, don't hesitate to contact us. We'll find it for you. Versus having 2 or 3 different accounts. If you have 2 or 3 different accounts, your certificates from different courses are going to be located elsewhere, and it's going to be really challenging for you to get them all together if you need them for your licensure purposes. So feel free to go into the university, take as many courses as you like. If you do have any questions or comments or problems with that, please let us know and we'll be glad to help you. If you do have continuing questions, or if you're listening to this webinar in a recorded archived event, please feel free to contact us with your questions, and we will get in touch with our guest expert to get those questions answered for you. Now, before we close out today, I've got one more minute, and I wanted to announce a couple of different events that are upcoming. First thing, 2 best practice intervention package updates. First, immunization and infection control BPIP that is currently being updated with the newest CDC guidelines that just came out for the 2018-2019 flu season. That will be released in October. The Fall Prevention Best Practice Intervention Package, we call it an update, but it's basically an entire rewrite. That BPIP is going to be released in November. I know many of you have been asking about it. It's coming forward. It will be here in November. Finally, 3 last save the date events for the next 3 months. First, in October, the third Thursday event. You know the CardioLAN rotates with the underserved population. On October 12th, 2 to 3 p.m. Eastern, Dr. Martha Sanders and Dr. Tracy Van Oss, they are professors of occupational therapy in the School of Health Sciences in Quinnipiac University in Connecticut, will be available, and they're going to be presenting Promoting Medication Adherence. Remember, this is occupational therapists. This is going to be brilliant. They're going to be able to share with us, those of us who are nurses, how best to utilize our occupational therapists in promoting medication adherence. Second webinar I wanted to mention is coming in November, on November 13th, 1 to 2 Eastern. This is going to be a broadcast webinar. And Mr. Thomas Heyman, who is the President and Executive Director of the National Sepsis Alliance, will present Sepsis in the Home. This goes beyond our cardiovascular population, but there are many people who are, this is something that's community-wide, nationwide, ongoing, so we want to definitely bring in the most current information to share with you. And finally, we come back around to our next CardioLAN. It is normally the third Thursday, but for those of you that have participated for years, you do realize that on December, this particular one has been moved to December 13th due to the holidays, 3 to 4 p.m. Eastern. And at that time, Dr. Wayne Castillo, the Director of the National Health and Environmental Effects Research Laboratory at the EPA, he's going to bring forward his combination of experience as both a cardiologist and his time with the EPA to discuss the challenges of particulate pollution and how it impacts not only our patients with cardiovascular challenges, but also our patients with respiratory issues as well. He's going to bring it down to the application level for all of us, and again, we hope that it will be turnkey, meaning attend the webinar, an hour later be able to implement it into your practice. We hope that you will mark your calendars and join us for all of these. I'd like to thank you for your time today, and everyone, have a great September.